T. I was teaching this course at Toronto East General, and I had started into guiding a meditation, and someone came in a bit late and said, "Is this CPR training?" And I said, "Yeah, just sit down." And they sat down, and I'm guiding them through the meditation. And a couple of minutes into it, the person, even though it's quiet in the room and people's eyes are closed, goes, "Is this CPR training?" And I said, "Yes, you're welcome, just follow the guidance." And then they go, "It's not the CPR I knew, I need my research." So I realized I have to be pretty careful not to confuse matters. I love this cartoon. He's the only person I know who approaches team building like a do-it-yourself project. And this is certainly not a do-it-yourself project. And I'm so grateful actually to the Department of Radiation Oncology. The radiation oncologists allowed me to pilot a mini version of the course. So the first time I ever taught the course was just a 3-hour version. Of course, it was the Department of Radiation Oncology, so they kind of created their own randomized controlled trial, but they self-selected. So you could choose to go golfing or do a half-day seminar. So it was interesting. So some of you have not been exposed to this before, and some may have. But also the radiation therapists generously allowed me to guide them through the course in the first 8-week iteration, and they helped me learn a lot in the process. I also have a collaborator in creating the curriculum, Mark Coleman. I have research collaborators, including Renat Neeson, who's the co-principal on our work, and Gary Roden, and now HR are also very supportive of the work, and many of the nursing staff are starting to come to me, nursing management, to offer the course to nurses. So now all the nurses in the chemo daycare unit have been exposed to the 4-week version of the course. I'll talk a little bit about the Cumulative Grief Committee, which even Mary Gospodarowicz received the minutes about, and she was very generous when I was bringing this together, because I thought this was going to be a tiny one-day workshop for oncology staff around the topic of cumulative grief, and it turned into maybe my retirement project, I don't know. And I'd also, I'm glad I gave a shout out to the foundation. The Gold Fine Memorial Award was given to me to help pilot this. That was through Mount Sinai, but our own foundation through the Corrigan Family Research Fund has been very generous in supporting our research. And we're desperately trying to get grants. So I hope that eventually this is how the hospital looks. But in reality, what I'd like to do today is just give you a little bit of an overview and take you on a bit of my journey in creating this course, help you to understand why I think it's important in a course that addresses wellness amongst healthcare providers that we have more components than just mindfulness, but rather we have the components of mindfulness, which is the presence component, compassion, and resilience, all involved in the training. And I'd like to give you a little exposure to the practice, and I want to save enough time for some discussion and get your input about some of the modifications that we're making as we go along. So, that said, if you're willing, let's just stop. And I need to do this. I've encountered many of you on 17A and B this past week. It's been very busy on call with very complicated patients, and while I thought I had time set aside to put this presentation together. I've been on the boards, so I need to stop and just take a pause. So if you all want to do this with me, and then you can have your eyes open or closed, but just really feel your feet grounded on the floor, and take 3 to 5 slow, deep, nourishing breaths. In through the nose and out through the mouth. In through the nose and out through the mouth. And in through the nose and out through the mouth. And then take a moment to notice your thoughts and what emotions you have and what's happening even in your body sensations. And now you're prepared to listen mindfully to the presentation. So that's the kind of quick exercise we do in the CPR training. But before we get to CPR training, I was taking a mindfulness teacher training year-long course, and I needed to create a project for it. And I thought my project would be this topic of using mindfulness to help healthcare providers in the oncology setting process cumulative grief. Because I found as I went through my own personal mindfulness practice that I really met the grief that I thought I had long processed. For patients who I had long and in-depth relationships with, and then they would die. And sometimes actually I shouldn't have said long, sometimes they were just intense relationships towards the end of somebody's life, and the person would die. So I brought together an interdisciplinary group here at the hospital to talk about this. And all I can say is they gave me grief. They all wanted to address the topic of cumulative grief. It touched everyone, whether they were a nurse, a social worker, an oncologist, a psychiatrist. There was another psychiatrist on the committee. Everyone had their own story of grief that was just stored in their own hearts. And how one person related that she would literally walk by rooms, and as she walked by rooms, think, oh, so-and-so died in that room, and so-and-so died in that room, and I was involved with this person. And so I thought I was really on track. So I didn't know this committee was going to actually give me a hard time. I should know better, right? It's the hospital. Why did they give me a hard time? Because as we sat around the table, the first thing they said is, you cannot call this committee the Cumulative Grief Committee. We don't want to come to something so depressing as that. But they also said, we need to address all these other things. And they just bombarded me with compassion fatigue and burnout and witness to suffering or vicarious trauma and work-life balance and organizational stressors. And how they then also wanted, at the same time as addressing that, to promote all these other qualities, such as well-being and resilience. That was my term for, I just listened to them, and these are the terms I came up with, having met with them 3 times. Awareness, compassion, self-compassion, empathy, growth, transformation, and connection. And I went out of those meetings thinking my head was going to explode, knowing that I needed more meditation myself. And I gave it a lot of thought. And it was the birth of a new way of thinking. Because here I thought I could just pop in and do something that would really transform people quickly. And I know that sort of transformation doesn't happen overnight. A one-day seminar is not going to do it. And I also listened to what they were saying about needing more bounce, needing more of the resilience piece. That's when I thought, we need resilience in this. Like, we really need to bring life into whatever intervention we have. So I created this model, but it came out of recognizing, as I reviewed the literature, I'm low tech, so I don't have a pointer, that all of these concerns that people have, that we talk about, like that I mentioned, the competing demands and stress, cumulative grief, vicarious trauma, empathy fatigue, compassion fatigue, work-life balance, and moral distress, lead to increases in burnout. So I think these are all a common pathway to burnout. And on the other hand, there are these buffers that the literature talks about. Well-being, ways of enhancing well-being, enhancing resilience, enhancing awareness, turning towards self-compassion, which was a really foreign concept to me. I spent a couple of years studying that personally, as well as trying to understand the literature, and compassion, connection, meaning, equanimity, and joy. So those things all buffer burnout. And at the end of the day, the healthcare outcomes that I became interested in ultimately looking at would be healthcare provider engagement, the health of our healthcare providers, retention of healthcare providers, as well as creating a culture of compassion. It was like I was having a conversation, I won't name who I was having the conversation with, but somebody said to me, but it's not going to change how busy I am. And I'm like, no, that's the beauty of applying mindfulness. We're not trying to change anything. We're meeting things as they are. We're becoming aware of things as they are and learning to accept them as they are without needing to change. But we notice. And I said, it just allows us, when we do get irritable or grouchy with our colleagues, to name it. And what we name, we tame. That's a phrase from Dan Siegel. So I think we can, in small ways, it doesn't make us all ooey-gooey, oozing in love, peace, and happiness, although that would be pretty cool. But it allows us to just take responsibility, I think, for how we, for noticing we're experiencing ourselves, and then being able to name it sometimes. I'm going to use foul language, but I was driving before I took on a mindful driving practice, and I was like late for something as usual, and my daughter was in the car, and I honked the horn, and then I turned to my daughter and I said, I can't stand this mindfulness stuff, because all it does is make me aware of when I'm being a real bitch. After that, I decided to become a mindful driver, a loving kindness driver, and it's worked. I'm now very chilled. Actually, I gave up driving. So I walk to work now because it just was like I was chilled, but I also realized how stressed I was driving. So anyway, it's interesting how mindfulness can just seep into your life. I also am interested in staff and patient satisfaction and in improving those things. And then, the mindfulness literature amongst healthcare providers would say that you actually can you can improve patient safety through reducing medical errors through mindfulness practice. So ultimately, we're not quite there yet, but ultimately those are outcomes that I hope that we can somehow measure. And if anybody is interested in collaborating on outcomes like medical error, and that sort of thing, if that's an interest of yours, please contact me. I'd love to collaborate on that. So in designing this curriculum, I had to recognize that healthcare providers have high incidences of stress, burnout, compassion fatigue, and yet they report a sense of reward and compassion satisfaction. And really, my theme is that healthcare providers, in the way we are, we're not broken. We're just human beings working in a really emotionally intense setting with competing demands. And I had to be very aware of that, because I really approach this as, I don't know what's best for everybody. And I do know that I care a lot about this hospital, I care a lot about my colleagues, and I care a lot about the patients. And I'm really human in how I work. And I've had to develop ways to remain human and not become overwhelmed by that. So I clear a lot of the experiences I have on a daily basis through using mindfulness practices myself. So that's one thing to recognize. The other part of that is that, and this comes out of some feedback from a grant application where someone said, how can you teach people resilience in 4 weeks? And I wanted to be able to write back and say, I'm not teaching them, I'm pointing to their own resilience. I'm allowing people space and time to tap into what's already there. And that's really crucial to me. Similarly with compassion, we often don't create space and time to really nourish these concepts, to think about them, nourish them, and recognize them within ourselves, and recognize our own needs for them. And I also recognize that there would be a benefit to shifting to and emphasizing wellness practices that are integrated throughout the workday instead of being relegated to after hours work. I learned that the hard way. The first few groups I did, I would go back to my research collaborator and go, oh, these healthcare providers, they don't do their homework. The patients do their homework. I teach all these mindfulness classes to patients, and they do it. And then I thought, if I were them, I probably wouldn't do it either. So I also had a component of the course anyway that was short practices to do on the job. And I love it when people do longer. We do, in every session that I run, we do some longer practices, but the emphasis is really on practices we can do in a incorporated, integrated way. So for example, when you walk into a patient room, often, and actually I learned from the radiation therapists, they have a motto, walk and talk, because time is of the essence. So I don't know how well this works in radiation, but that even to take a moment to just ground your feet, that just brings us into our own bodies. And then we recognize, oh my God, I had this happen yesterday. My heart is racing because I'm dealing with this agitated patient, and I'm not sure I'm going to be able to protect the other patients and the nurses, and you know, it's a challenging situation. Okay, just ground, breathe, do what you can do, you know? And so, but it really just starts with feeling your feet on the floor. So we practice short practices like that. Another one is that we dot wash stations so that people are given red dots, and when you see a red dot at a wash station, you do that stop exercise. Stop, take a breath, take 3 breaths. 3 breaths is the magic number for shifting from the sympathetic nervous system to the parasympathetic nervous system. So that's why I emphasize 3 to 5 breaths. And then just really observe your experience, and then proceed to wash your hands mindfully. I should actually collaborate with ID to see if we could reduce the incidence of infection by mindful hand washing. But really, it's just because we wash our hands so many times a day. If each time we stop to wash our hands or put that awful smelling sanitizer on our hands, you know, that could add up to, I don't know, how many times do you wash your hands in a day? A lot. Like, you know, you could be doing 15 minutes of meditation without even trying, you know. So these short practices, I learned both from the people not doing the home practice, but people coming back and saying they were doing the work practices, and also in our qualitative study, people talked about just what a big impact those practices had. We were quite stunned by their reports of that. So I recognized that shifting to an integrated way of wellness really made sense. Mindfulness, there's lots of evidence that mindful self-awareness is really, there's lots of evidence for promoting emotional well-being as well as physical well-being through using such, and that it will also help us accomplish high-quality patient care. In the American Palliative Care Fellowship training, it's now mandated that there be self-care integrated into their curriculum. In the American Oncology Fellowship training, they talk about self-care, but they talk about it in terms of professionalism. And the way they define self-care really isn't about so much, the way I saw the definition, about looking after your well-being as how you are as a professional. This, for sure, assists us in how we are as a professional. Being aware helps us create boundaries. It helps us know what our limits are. You know, there are certain days where we just have to recognize that we can't give patients everything they want. You know, you have 20 patients in a waiting room and somebody needs time just to chat. It may not just be able to happen exactly the way the person wants. But when we're aware of it, we can name it for the patient. We can say, you know, I really have to apologize. I can see that you want to talk about this today. Today is just not a good day. We're really behind, but I'd be happy to book you into another appointment. You know, that sort of thing. So it really helps us to both become aware and then to take action if necessary. The other thing about this program that was really important to me is, as I read the literature on healthcare provider, oncology healthcare provider wellness programs, most of them have not been sustainable. So they're either 8-week programs or 10-week programs, and so people, once this study's done, they don't seem to continue to offer them, or they're offered sort of very peripherally, so they don't become central. The work isn't really focused on how it translates into how we do our jobs, and even the practices they teach, because they're not integrated into how people are working, I don't think they're even personally sustainable. So there's lots of barriers to creating this kind of intervention, and no big surprise, but there's a reluctance, even though we have such high levels of burnout, as I'll just very briefly give an overview of. There's a reluctance, particularly amongst physicians, to seek help. In one study, they found that amongst those who self-identified as having a significant depression, only 25% of them sought help, which is really unfortunate. You know, there's stigma, there's time, there's concerns about confidentiality, there's concerns about punitive responses, there's concerns about embarrassment, about being in the patient role, and we've learned a lot about this in the first 10 groups I've run. So I've now delivered this intervention, CPR, in its full form 10 times. So just about some of these key concepts that have gone into the thinking, I'm sure you're all aware of what burnout is, the three components being emotional exhaustion, depersonalization, and diminished sense of accomplishment. The highest levels of these subcategories fall within emotional exhaustion. And for me, this is the most recent study that I'm also quite sure you're aware of because it was published in JCO. And there were high levels of emotional exhaustion amongst 38% of oncologists, depersonalization 24%, and diminished accomplishment 13%. And at least 45% of people had at least one area where they were considered burnt out in these three subgroups. And this affects patient care, and they also found that it's correlated to number of hours people work beyond a certain number of hours and beyond a certain number of patients. And it's also linked to satisfaction and work-life balance. Having said that, even when people have symptoms, significant symptoms of burnout, when asked in this same study, 83% of people still said they would become a physician again. So I think that's just amazing. And it speaks to how we've shaped this program. And in particular, most of them said they would become an oncologist again. Levels are also high amongst oncology nurses and social workers, 33% and 25%. Another study from Europe, very similar numbers, except they looked at a variety of healthcare providers. And so again, we're seeing very high levels and we're not addressing this. If patients were walking around with a medical condition that was happening at this rate, people would scramble to, I think, to study it and find treatments for it and find evidence-based treatments for it, because that's the other piece of what I'm trying to do is create an intervention that's evidence-based so we can put it to randomized controlled trial and be able to disseminate the work so that it's sustainable both here at PMH and beyond. The other thing about the literature is that I find really sad is 16 years ago, we had just about the same levels. This is the Ontario study that was done by Cancer Care Ontario. And so in 16 years, we're pretty similar in terms of our rate of burnout of oncology physicians and oncology staff. So I really think that's a call to action because there's all these costs of burnout that I'm sure you're aware of, personal costs as well as organizational costs. In terms of studies on cumulative grief, there was a recent qualitative study, or relatively recent qualitative study, and what really came out of that is that physicians, this was done amongst medical oncologists at Sunnybrook and PMH and one other institute, and they published a series of papers, and that there's no protocol for people that's taught to people for dealing with their grief. There's a personal impact on the person and it spills over into their medical care. It affects emotional balance and it often results in oncologists choosing to distance themselves from patients. There's an impact on the self in terms of burnout, depersonalization, and compartmentalization. And there's impact on care, so distraction, it affects treatment decisions and withdrawal. And again, it's just so encouraging to me that also in the study, physicians said they wanted training, they wanted acknowledgement of the grief, because it's often unspoken. They wanted institutional support. They wanted vacations and sabbaticals too. I mean, we can't fault them for trying. Compassion fatigue, I don't personally really focus on. The measure we're using is actually workplace engagement, which pairs with burnout. Compassion fatigue is really a form, and even the person who coined the term said it's just one form of burnout, and it's very similar to emotional exhaustion. It sort of crosses between the different subtypes, and I like how clean the conceptualization of burnout is. I think compassion fatigue hasn't, the concept and parsing out where it's the same and where it's different from burnout hasn't really been studied, but I think people like the term, so it gets used a lot. And in the course of, it's a course on mindfulness, so I just thought I'd put a slide on what mindfulness is so we can be talking the same language. Basically, it's awareness that comes from paying attention in a particular way, on purpose, in the present moment, non-judgmentally. Another way of saying that is present moment awareness. It really is shifting from the doing mode to the being mode, from the sympathetic nervous system to the parasympathetic nervous system. Probably most important, it allows us the freedom to choose a response as opposed to operating an automatic pilot and being reactive. When we're reactive, we can regret some of the things we say or do. When we are mindful and respond from a place of awareness, we're much more likely to have a skillful response. Our message may be the same, but it can be heard better when it's given skillfully. And there's certain kinds of attitudes that are really embedded in how we are mindful. In particular, the sense of curiosity about our experience, and as opposed to judging our experience, allowing our experience as opposed to pushing it away. That's actually the magic of facilitating mindfulness groups for cancer patients. It's been the most stunning way I've discovered to help people cope with uncertainty and to help people come to a place of accepting the wholeness of who they are without needing to change who they are. So that means cancer can be a part of it, but so can other things. The adolescent and young adult program, the feedback we had from doing MBCT with that group really talked a lot about that. And it's about befriending ourselves and kindness to ourselves, making space for patience and kindness for ourselves, and through that for others. But I thought I would just highlight that this is not a new concept to be used with at this point in time. In 1999, Ronald Epstein wrote in JAMA a paper called Mindful Practice, and it's the hallmark paper of mindfulness in the medical system. So his group offers and has done studies with an 8-week program in the pure MBSR, mindfulness-based, well, not quite pure, they add a communications piece, so I think they call it mindfulness-based stress reduction and communication or something like that. And the problem with it is that it's an 8-week program offered like for 2.5 hours, 8 weeks, plus a 7-hour retreat. And yeah, I see your face, Fifi. Like, it's great, and people who are really keen will do that. I mean, to do training, you have to do those programs and much more. But for many people who are already feeling stressed, to start at that as an access point is a lot. There's another study that I thought was really interesting in that they actually paid, it was one of the only randomized controlled trials in using an MBSR intervention, and they shortened it to 1 hour. And the randomization was you could have an hour to do whatever you wanted or an hour to do the mindfulness class, and they paid the physician's time, and it was 18 sessions. So paying, and they had 200 people randomized, so that's a lot of time, money. I really want to know if we can get by with a lower dose than 18 sessions or 8 sessions. So we're moving this along. So despite the fact that there's lots of talk about and lots of papers written about mindfulness for healthcare providers, most of them are just pontificating that it would be, or speculating, I shouldn't say pontificating, speculating that it would be a good thing. But in this wonderful meta-analysis done by a psychologist at Sick Kids, they boiled down, I think they started with something like 2,000 hits in studies picked up in PubMed, came down to 12 studies met criteria for meta-analysis, 5 with a randomized control arm involving physicians, 4 with a randomized control arm involving medical students, and 3 single design. They weren't going to have any single design groups, but they just didn't have enough for their meta-analysis, so they added methodologically sound single group design done for physicians. And so when they did the meta-analysis, they did actually find, using those 12 studies, that mindfulness interventions are associated with a decrease in anxiety symptoms and an improvement in burnout symptoms. So it's nice that mindfulness crosses over both of those areas. Amongst the studies, they were just interventions. They all, most of them involved mindfulness, but they didn't all involve mindfulness. Some were more pure cognitive behavioral psychoeducational interventions. Okay, so moving to why incorporate resilience into this kind of program. So we have mindfulness, and there's evidence that mindfulness is important. I think resilience is important because it's something we all have, and it's something that we just need to foster and nurture through giving time to it. Again, Epstein wrote about physician resilience and what it means and how to promote it. But this was based on looking at the literature on resilience as opposed to an actual study. There is evidence, theoretical evidence, that monitoring self-awareness and self-monitoring, self-regulation, and resilience and public accountability would be really helpful. And that mindfulness is a part of that. The one study, so there are 2 fairly good studies, but one only had, they're both qualitative. One had 17 participants, and they specifically asked family physicians who were nominated as being resilient by their colleagues to answer questions about what resilience is, because we don't really know. And they boiled it down to these 4 different thematic categories involving attitudes and perspectives, including valuing your role, maintaining interests, developing self-awareness, and accepting personal limitations, the balance and prioritization, including limit setting, effective approaches to managing the onslaught of information, so continuing education is important, as well as honoring oneself, practice management style, and supportive relations, both personally, professionally, and communication, all were found to be components of resilience. So then another study was done 5 years later that involved 200 patients and 200 physicians, and they did semi-structured interviews, and they found the themes that came out of those interviews about what resilience are gratification from the doctor-patient relationship, gratification from medical efficacy, and the resilience strategies in particular came around practices and routines, and they listed a whole lot of them, but they include things like cultivating leisure time, cultivating relationships with colleagues, friends, families, but also really recognizing one's limits and being able to meet one's errors in their practice. And mindfulness really helps one do that. And self-compassion takes it a step further, because there's evidence in the self-compassion literature that people who are able to be compassionate with themselves, so people who have higher scores in self-compassion, are better able to take ownership of mistakes. And so that is one reason, aside from just, it makes sense that we want to nourish compassion to ourselves. Well, it didn't make sense to me initially, because I'm like, why? Isn't that all about just giving compassion? But nourishing compassion within ourselves, we can address this, and through that build resilience. Also around reflection, boundaries, talking about stress, so those kinds of routines. And then they also talked about 8 strategies of practice attitudes, so acceptance and being realistic, self-awareness and being reflective, active engagement with challenges, mindfulness. That's like the definition of mindfulness. So again, what we're doing in CPR training is bringing in mindfulness, self-compassion, and out of that, a lot of resilience may possibly grow, or at least be recognized within the individual. It's also about recognizing when we need to change our circumstances, when we need to modify our internal distance and become more of an observer and step back, appreciating good things. So in the CPR training, we do lots of work in sympathetic joy, where we look at things that we feel good about, something that has happened for us at work, and it's very quick in the way we turn to this. But then we also do a meditation where we think about something that one of our colleagues has done that we really think is spectacular. And so we learn to really build that appreciative capacity for others as well as ourselves. The other thing about practice attitudes is recognizing the person behind the symptom. So, I mean, when I had a poster actually at the Personalizing Cancer Care conference in February, and I was just really, is that what it was called? Personalizing Cancer Care? I was like, wow, this is like the only poster that's like personalizing, humanizing. I guess I was thinking humanizing cancer care. But it was like great to be there and to hear some of the basic science talks and recognize that, you know, it takes a village. So I can contribute what I can contribute. And someday I really, like, I'm collaborating with Madeline Lee. We put in a big grant to also look at biomarkers amongst people taking our courses. So we're specifically interested in looking at telomerase levels to look at the possibility that mindfulness, and there's emerging literature about this, that mindfulness can actually promote the maintenance of telomerase levels, which is associated with keeping the cap on the telomeres. And I don't need to tell you that. And also C-reactive protein and some of the pro-inflammatory cytokines. So we didn't get funding for our grant, but we're going to try again. So the other thing that has changed on this journey is the recognition that there's this whole literature now on work engagement. And the really interesting thing is that work engagement is a positive, fulfilling, work-related state of mind. And it involves vigor, absorption, and dedication. And it's associated with high energy, enthusiasm, and high self-efficacy. And there's a scale to measure it. And Maslow, who was the originator of the Maslow burnout scale that is the gold standard, got together with Baker, and they studied this, and they found that they're the same concept. They're two poles of the same concept. And so I wanted to study burnout, but Renat Neeson, who's my co-principal investigator, said, no, we're not taking the depressed route. We're taking the engaged route. And so we're actually using the work engagement scale, which is really exciting. But it maps exactly. So vigor is mapped to emotional exhaustion, absorption and cynicism, and dedication and disillusionment. And so, and I've just showed there CPR training, how it targets different levels of work engagement or burnout. So we've specifically integrated practices to address enhancing vigor, absorption, and dedication. Oh, and sorry, I was just a little out of order there. The other thing is that there's now one study that has shown that mindfulness is associated with resilience, and that's associated with reducing burnout. So that's really exciting too. So in terms of compassion, presence, and resilience training, it's unique because it integrates these three concepts. So compassion, fostering self-care and responsiveness, both to ourselves and others. So compassion, as we define it, is the ability to, it's not really the ability, it's the quivering of the heart. It's the sense of witnessing another's suffering with the wish to alleviate the suffering that we experience amongst others. But we can turn that on ourselves. So when we ourselves are suffering, and in the course we talk about, well, suffering sounds like such a big word, but in fact we all suffer in many ways throughout the day. So we each for ourselves define what suffering is, and then we learn how to be responsive. And improving, and there's studies to show that improving self-compassion is associated with improvement in compassion for others. The course has mindful awareness presence to promote self-care and resilience. And it's situated in the workplace, and I've already talked about that, the one thing that I didn't talk about was that along with really now accentuating the workplace practices and assigning workplace practices to participants, we truncated the course from an 8-week program of an hour and a half for 8 weeks down to 4 weeks, an hour and 15 minutes. And once I did that, the hospital engagement committee heard about this and came to me and said, could you present to senior management? So there was something magical in shortening the course. My own hope is that, one, that a smaller dose is helpful and works, and so far our qualitative study is demonstrating that people are getting benefit or reporting benefit. But also my thought is that once we deliver a 4-week intervention and we begin to build practices, we can have ongoing practice groups in the hospital. We can also, for example, the way it became a 4-week, I'm so practical. The way it became a 4-week course is the McCain Pancreatic Center came to me and said, will you do a course for us? We experience a lot of grief because we still lose a lot of patients, and so could you offer the course? And I said, yeah, well, it's 8 weeks. No, we can't do 8 weeks. So I said, okay, how about 4 weeks? 6 weeks? No. So we negotiated 4 weeks. Okay, 2 hours? No. So it came down to an hour and 15 minutes. But then my thought was we could get a base and they can do the base course. And from the base course, then if people want other trainings, like how to manage medical error or how, what to do when there's a medical error, or how to particularly process cumulative grief, then we can offer some smaller modules. So I'm sort of seeing it as the CPR that I'm offering now is like the basic CPR as opposed to, it's BCLS as opposed to ACLS, and ACLS can come down the road. We've also are working on an online education platform resource, so to help improve the sustainability. And we're really interested in making this sustainable. So at this point, I'm just going to say that our preliminary qualitative study has said that there's benefits, and the benefits, the thematic benefits, I won't read the quotes in the interest of time, but that it's learning to pause, it's finding for oneself a working definition of stress and self-care, it's learning to be fully present, and they also really appreciated the organizational acknowledgement and recognition that there is stress in the work we do. The challenges reported were developing the practice, and that's, I listened and we have integrated more workplace practices. I think we have 30 workplace practices, but they're like from 2 seconds to 3 minutes long, as opposed to giving people 20 or 30 minutes of home practice to do a day. But one of the spontaneous theme that came out uniformly was the challenge of displaying vulnerability to colleagues. But interestingly, in the study, it also showed that there was both a benefit and a challenge and so there was an interaction between the display of vulnerability to colleagues. In particular, people found that they needed to be able to be vulnerable to feel more bonded to their team. So we don't see the vulnerability as a bad thing, but again, I have modified some of the delivery of the course so that people can do a lot more personal reflection without asking them to reveal to the group what their thoughts are. It was always voluntary anyway. And we also do more sort of small group work as opposed to pair work. People found that breaking into pairs and discussing their experience was a little too intense. So we'll see as we go how that is. And I think that's a good point to stop. Other than to say now we've added a quantitative portion to our study. We're at the point. So we're studying burnout through looking at workplace engagement and perceived stress, and hoping to eventually study these other concepts. But we've kept it small and simple at this point, so the two measures we're looking at are workplace engagement and perceived stress. And so that's where I'd like to stop and invite any questions. We have like 2 minutes, I think. Francis?
It's probably an hour-long talk.
Okay.
But you've never mentioned any gender differences. And I know that Donna Stewart, many, many years ago, looked at working mothers and did hormone levels and found that their steroid levels in the morning as they were trying to get the children to school were higher than anything they'd ever seen in any other group.
Yeah.
And I think the stresses and emotional response to stress among working women, and maybe even more among working mothers, is extraordinary. And you didn't mention that, and have you studied that in particular?
Well, the interesting thing is, in the way we report our qualitative data, so we've just finished a paper, and it was written as, as it made it seem like there were men and women in the group, and the first number of groups we had no men. It'll be once we do the, and actually I have to say, so there's a bias, right? Because we've offered it to all the chemotherapy nurses, probably 80% are women. So that'll be interesting to look at. I hear ya.